So here we go. So I did want to provide Regina with an opportunity to introduce herself. Some of you may have met her yesterday in your tutorials, others maybe not. So Regina, if you want to introduce yourself, maybe what your interests are related to health and geography, anything like that.
Yeah, no. Oh my gosh, there's so many people coming in all at the same time.
I know, some latecomers.
Okay, so my name is Regina, and I'm one of the TAs in this course. So currently I'm in my 4th year of my PhD, so been around at Mac for a while. My research interests is mainly kind of concerning the aging population and how the labor force is impacted by the aging population. And right now my research is primarily focused on, it's a collaborative research process with a workplace and kind of designing an intervention to kind of assist with their employees who are dealing with elder care type issues. And it is very COVID heavy just because a lot of long-term care has been impacted by COVID. So there is now a very COVID heavy emphasis in my research. And yeah, that's
Do you enjoy your research so far, despite the kind of COVID focus?
okay, now I do, but it was really stressful back in March because I just started data collection and then that was put on hold because I could no longer do in-person research. So now my entire research is online, which is fine. It translates pretty well online, but it was just a stressful few months, kind of redesigning my study last minute to kind of accommodate for the COVID restrictions.
Yeah.
But it's interesting now. It's a lot of interesting data I have.
Good. So luckily, some of us have been able to pivot during the pandemic, so that's always a good thing. Okay, so moving on. In yesterday's lecture, we started to talk about some of the ways that geography, so locations and places, can impact health. We talked about some examples that showed direct ways and indirect ways that geography can impact health. Some of those that we talked about were things like distance, some stressful places. We talked about stressful jobs, for example. But how do we actually measure these things? How do we measure their impact? So today I'm going to spend a lot of time talking about that. We're going to go over some health indicators, and then we'll talk about study designs towards the end of the class. Regina, I can see that quite a few people are still entering now. So hopefully if you can stay just a few more minutes to kind of accommodate any latecomers, and then I'll let you get on your way as well.
Oh yeah, no problem.
So just an FYI, guys, please try to show up on time as best as you can. It's just a little bit distracting for us to admit as we go along. So in sum, it kind of depends on what kind of geography and what kind of health we're talking about, right? That's obviously going to have an impact on the kind of measurements that we want to use. So this will also impact, naturally, our choice of methods. And that will also largely depend on what kind of question we want to investigate, what kind of question we're trying to answer. So to begin, qualitative methods. Usually the focus in qualitative methods is on understanding how and why places impact health. So we're really mostly focused on answering those types of questions, the hows and the whys. For example, maybe we're interested in what kind of characteristics of urban parks might influence levels of physical activity, right? So in the picture there, you see two sort of more senior aged folks using equipment in a park. Particularly relevant to qualitative interviews, we might want to conduct those in order to actually get a sense of why residents are using them or not using them. We might want to know about their experiences using certain park aspects. Do they feel unsafe using them, for example, or are they confusing to use? So in that sense, we can use qualitative methods to get a really rich understanding of what people are doing, their behaviors, their experiences. So generally, we're talking about collecting data on or about people and their knowledge, their experiences, or their beliefs, attitudes about things. Now, why would we care about that? Why are these things useful to us? Partially because healthy public policies are not only shaped by things like numerical evidence, right? We want to know what people's experiences are. We want to get their feedback on stuff, especially governments who spend a lot of money on things like park initiatives or any sort of healthy built environment policies. They want to make sure that their money is well invested, that they are spending money on things that people actually use and enjoy and that won't go unused. So in general, when we talk about qualitative methods, we usually talk about interviews, focus groups, ethnographic studies, so things like that. Now, we're not going to spend too much time talking about qualitative methodologies today because they are going to be more of a focus in your assignment number 2. So we'll kind of move on for the time being. But that is to say that qualitative studies are very valuable. So I did want to illustrate one example because I think qualitative studies tend to be forgotten a lot of the time in comparison to quantitative. They maybe don't get as many shout outs as quantitative studies do. So in this particular study from 2016, it was a study by Ng et al. They were trying to figure out how workers who were working in a factory in the UK were being exposed to harmful chemicals. They found out that they were being exposed based on blood samples. And so they were doing blood testing to see levels of chemicals. And they were surprised to see that some of them had high levels because they knew that the workers were wearing personal protective equipment, PPE. So they're trying to figure out, well, how could this be? So they decided to do interviews. They decided to observe the workers as they conducted their work over the course of a day. And what did they find out? Well, if it's any indication by the picture there, they found out that nail biting was a really important behavior or habit that they observed there. And it was really important in the sense that it provided that hand-to-mouth contact, right? It was that exposure route that they weren't really considering before until they did this kind of observation. So what they observed was that even though they were wearing PPE as soon as workers went on their lunch break or went on their smoke break, right, they were using their hands to either smoke or eat, and then that could lead to the ingestion of the chemicals from their workplace. So this just sort of illustrates that a lot of phenomena are quite difficult to study, especially in the real world, unless we do things like observation studies, unless we interview people, unless we get that sort of direct feedback or experience from them. So again, qualitative methods is a really, really valuable part of research in general. But for the rest of today, we're going to focus mostly on quantitative stuff. But I did want to introduce it right off the bat because, again, we will kind of draw back to it for the purpose of assignment 2 later in the term. So moving on to quantitative methods. In comparison to qualitative, the focus on quantitative methods are usually to understand questions like which, where, and when. So, for example, do people who live closer to mountains have better health outcomes than those who live further away? So usually we're talking about collecting numeric data, spatial data, like location coordinates, for example, census data, satellite imagery, things like that. Now, in this particular example, how would we go about using quantitative methods? Well, we could take the average distance of residents in a place like Calgary, which is only about an hour's drive from mountains, right? Like Banff National Park, for example. You could compare that with a city like Edmonton, which is a little bit further away. It's about a 3-hour drive from mountains. Based on that, you could compare the rates of some health outcome that you're interested in. Maybe you're interested in something like obesity. So you could use census data or you could use surveys, and then you could try to make those connections, right? You could look at correlations between that health outcome and their distance to something like mountains. So that's to say that quantitative methods are often used, especially in epidemiological studies or experimental studies, and we'll talk about some of those later today. Now, quantitative methods are also very valuable, equally as valuable as qualitative studies, because we can also learn some pretty neat things from them. For example, you can quantify the impact of some sort of geographic feature on health by really being able to establish relationships. So quantitatively, you can do a lot of statistics and things like that, which can help you sort of assess what impact some geographic or spatial feature has on health. So, for example, in the study from Hyun and al. In 2010, they looked at residential proximity to highways, and they wanted to know what kind of impacts your residential address and the distance to a highway might have on childhood asthma. So what did they learn when they compared those distances? Well, they found that children living less than 2 miles, which is about 3 kilometers or so less than, let's say, 3 kilometers from a highway, those children were twice as likely to have uncontrolled asthma compared to the children who were living further than around 3 kilometers. And they did that by measuring proximity to highways using the children's residential addresses. So they just mapped them out and then they calculated the distances to the closest highway. They matched that, of course, with the doctor's medical records about the children themselves. So individual level data from the physician's notes and records. Now, I'm talking about this because these are the types of studies that you'll be assessing in assignment 1. And assignment 1, I think you'll come to see, really explores a variety of different studies, a variety of different methods. So it's sort of meant to help you get comfortable, especially for those of you that maybe haven't spent a lot of time really dissecting health studies. This might be a first opportunity to really be able to do that. So hopefully you'll learn a lot in the process. Now, I chose a study like this as an example because personally, it always kind of blew my mind. I live in Toronto and frequently, at least pre-pandemic, on my way into the downtown core, I would pass sort of the Gardner Highway, the Gardner Expressway. And it would just really shock me to see some people's condo buildings like literally on the side of the highway, essentially. And, why do we do epidemiological studies like this? Well, it potentially has some policy impacts, right? Maybe if we did more studies like this, maybe if we paid a little bit more attention to studies like this, we might actually think twice about building residences so close to a highway. So in a sense, hopefully, I'm sure these researchers hope that their studies are being used for policy impacts and to really influence healthy behaviors and so on and so forth. Now we're going to move on to indicators of health. Because obviously, as we talked about yesterday, health status is not always easy to figure out in and of itself, right? Someone's health or disease status is not so black and white. It's something that's kind of worth discussing in a little bit more detail. So a lot of times health studies will use both qualitative and quantitative methods to examine relationships between, as we talked about, geography, so places or locations, and their impact on health or ill health or diseases, in other words. But how are some ways that we measure whether an individual or a population is healthy? So I wanted to ask you guys, what do you think? What are ways that we can actually measure whether a population is healthy, whether individuals are healthy? What are some indicators that we might use to be able to come to that conclusion? Any ideas? So if they don't have diseases, how happy they feel. Yeah, so you could use mental health indicators, for example, life expectancy. Yes, some of you are observant there in the graph on the slide. Yep, amount of exercise. Yeah, so their level of physical activity might be an indicator of good health. Infant mortality rate, yeah, that's one. Investigating quality of life, absolutely. And we will talk a little bit about that. Any other health indicators? So yeah, I think you guys got most of them. Others might include something like fertility. Someone asked one more thing. Regina, you'll be heading out. Yes, that's fine. Thanks so much for your help. Looks like most people are here, hopefully.
All right, no problem. Have a good lecture, everybody.
Thanks. See ya. Matthew says obesity. Yep. So that might indicate the health of a population potentially. It might also indicate some other things because obesity is, of course, related to lots of other health outcomes. Great. Yeah, so some other examples that I wanted to bring up were things like birth weight. We talked a little bit about that yesterday. Even something like the number of free hospital beds or their hospital capacity could really indicate that. So it's not just individual kind of medical diagnoses, but also health infrastructure in a country could be a really good indicator of what the health might be, because if people have access to health care and health resources, then they're more likely to be healthy. Now, why do we need health indicators? Why am I talking about this? Well, for one, they allow us to compare the health of populations in different places. And they also they allow us to observe the impacts of policies. So if we're instituting some sort of health intervention, we rely on health indicators to actually be able to tell if they're working, right? If we see an improvement in something like life expectancy, then it's more likely that whatever we change, whatever policy we instituted is actually working, it's doing its job because it's indicating that. So this brings us to measures of ill health or disease. So there are plenty of ways to tell if a population is healthy, but there are also some ways that we rely on to tell if a population has diseases or death as well, mortality. So this is something called the disease burden, and it's a type of study or a type of methodology, you could call it, that was coined in the 1990s, and it describes the total impact of some health problem in a region or a country or even on a global scale. Now, these were really popular and they remain very popular studies to do because they include the sums of various measures like mortality and morbidity, as well as the economic costs. So they really allow you to get sort of a big picture look at how big the problem is, right? Like what extent the health problem is in a society. You might be able to tell how much money is spent on it, which might mean that you can actually plan your financial policies in a given country based on how much money you know you need to spend on particular diseases. So these types of studies are really, really useful, and a lot of governments like to do them for that reason. Now I'm going to talk about some measures of morbidity. So going into some of those indicators of ill health. One of them is incidence rate, which I think many of you are probably quite familiar with, especially during these times. Does anyone want to tell me what kind of incidence rate is in the graph there on the slide? Any guesses? Also, if some of you want to speak up via audio, please feel free to. I definitely don't have to be the only one talking. So someone says COVID cases, active COVID cases. Yes. Ding, ding, ding. Yeah, so this was, and you can tell when I made this slide, it was sometime in November. So we saw obviously the first wave of COVID cases, and then we started to enter that second wave right around the time that I was working on these slides originally. So yeah, the incidence rate of COVID, active COVID cases is in the slide. Now, what does that mean? What is an incidence rate? So it is the rate at which new cases of a disease occur in a population during some specific time period. Now, I've bolded new cases because that's really the key part of the definition of an incidence rate. That is what differentiates it from other rates. So what's important to note is that once a case becomes a case, they will no longer contribute to an incidence rate. So take that in for a second. When you're diagnosed with a disease, let's say asthma, you're only diagnosed once, right? You will never contribute to that incidence rate again for chronic diseases, I should say, because once you have something like asthma, you're not really cured. You will always have asthma, it's assumed. You might have ways to manage that asthma, but for the most part, you will not contribute to some incidence rate in the future. You'll only be considered an incident case once. Now, that's quite different with infectious diseases. For example, you might have the flu more than once in a year, especially some of us who didn't get a flu shot. Maybe you get sick more than once. So you can actually contribute to an incidence rate more than once if it's an infectious disease that we're talking about. For something like COVID, we don't actually really know, in large part because we don't know the full extent of the immunity period. If you do have COVID once, we're not actually sure how much time passes before you might be susceptible to getting it again. But for the most part, most infectious diseases you can get a second time, which means you can be an incident case again. But for chronic diseases, usually you're only considered an incident case once. This is also why you might see in some news articles, for example, or in some health studies, what they call a first episode incidence rate. So that's sort of to differentiate the fact that they're only looking at people with the first time that they're having that disease, whatever it is, or they might call it an all episode incidence rate. And so this is meant to encompass the fact that some people might get that disease or that health outcome twice, whatever it is. So hopefully that makes sense. This brings us to prevalence. Now, prevalence is somewhat similar to incidence in that it is a measure of disease, a measure of morbidity. But what is quite different about the prevalence is that it's a proportion of a population that's diagnosed with a disease during some point or during some period of time. So rather than new cases, it's considering all cases, right? It could be cases that were diagnosed that day. It could be cases that were diagnosed that year. It could be cases that were diagnosed 10 years prior. It's just looking at all of the people in a population with that particular disease. So for example, in the figure there, it's looking at asthma prevalence in the United States in 2018. And so what it's telling us, for example, with a child, is that 7.5% of all children in the United States in 2018, whenever it is that they took that survey, 7.5% of all children had asthma. So it's quite different from incidence, but it is a really useful way to get a snapshot of the current state of a disease at a given point in time. Usually it's used for something like asthma, like other diseases that are quite stable, right? Not diseases that might have spikes up and down. And again, this is because for something like an infectious disease like the flu, when someone only has the flu for maybe a week or two, it wouldn't really make sense to take a prevalence of how many people have it because it would be so quickly changing. The rates would be really unstable. So that is the difference there. Now we'll talk about some measures of mortality. So mortality rate is the number of deaths occurring in a population during some specific period of time. You can further subset that into infant mortality, for example, or maternal mortality. And there are many other types of mortality that other people might be interested in or that you might come across in other studies. There's also something that we call the case fatality rate, and that is the ratio of deaths that occur from some sort of disease to the total number of cases due to the same disease. So many of you will probably come across these in various health studies. Now, something I did want to mention are HALEs, something that we call health-adjusted life years. And they're really useful. They often do come up in burden studies because they combine measures like morbidity and mortality in order to estimate the number of years that a person is expected to live in good health usually. Now, similar types of measures that are related to the HALE are QALYs, so QALYS, and these are called quality adjusted life years. And this takes into account life expectancy as well as the quality of the remaining life years of that individual, summed to the population level. Another measure that is worth talking about are dailies. And so these are disability adjusted life years. And this constitutes the years lived with a disability and the years life lost. Now, I will never expect you to be able to calculate these things, so you don't have to memorize their formulas by any means. It's just helpful to know generally what they are, what their differences are, so that if you encounter them, you know what they mean and you know how to use them potentially, or you know why we might use one over the other, for example. So this is to say that there are some problems with these measures. So that's why certainly in epidemiology, you might not encounter them a lot in population studies that aren't at the global scale because they might not be that useful. certainly for something like disabilities, right, for dailies, there's some controversy there because some argue that a daily measure assumes that the lives of disabled people somehow have less value. And a lot of people would say that that is absolutely not true, that, you know, we shouldn't look down upon years lived with a disability. We should just be focused on providing supports to those people that might need them. Otherwise, you might also consider that how we perceive the quality of life could be quite subjective based on where you live. So for something like obesity, in many parts of the world, obesity is not even really considered a terrible disease, right? It's sort of a fact of life for some aspects of people or some aspects of society in many places. In others, something like obesity might be considered a health affliction that should be cured and that should absolutely be addressed. So it's not always that easy to even have a standardized definition for what it is that would constitute some of these measures. So that's why there are some problems with them. Now, I talk about this because why is it important to define these health indicators? Why am I kind of going through the trouble of doing that? Related to that question is why would we want to standardize them? So I'm going to ask you guys, why do you think health indicators are important and why would we want standard definitions for them? Any ideas? Sarah, yeah, go ahead.
Being like knowing the values related to the measures can help like improve quality of life or like lifespans.
Mm-hmm. So if we define them, we can hopefully address some of these problems.
Yeah.
Sydney says it's hard to compare if things are not standardized. Yes, absolutely right. So if we standardize them, we can compare them a little bit more easily. Yep. Any other ideas? Get data from standardized measures to create new policies based on data. Yeah, so to inform evidence-based policymaking, absolutely. Any others? Standardized measures allow for a larger data pool. Yeah, absolutely right. So if people are using the same definition to define some disease, then we can actually have more data points because everyone has some consistent formatting. Universality, yeah, essentially. Yeah, so you guys are definitely on the right track there. Now, this is important because you'd be surprised how little consensus there is globally around the world in terms of definition disease cases. How they define a lot of things very substantially, even here in Canada. For example, I work with a lot of cancer data in my research, and you'd be surprised at the fact that many provinces actually use different standardized codes to define different cancer types in different ways. So not even everyone in the same country necessarily uses the same definitions in terms of how to classify diseases. So this is a huge, huge problem, not just when we talk about global health, but also even here in Canada. So something I did want to mention is this idea of a disease continuum. Now, a disease continuum basically shows us that, yes, disease is hard to diagnose. It's hard to define in a standard way because a disease is really fluid, right? You don't suddenly wake up one day and have a disease. Usually it's over the course of someone's life that you sort of develop a disease gradually, especially when we're talking about something like a chronic disease. So this idea of a disease continuum really shows that you're essentially starting off from a place where you're not at risk for disease and usually especially public health, would try to intervene. So they might introduce some sort of prevention measures to make sure that you don't become at risk of a disease. But for many people, they do, especially for factors related to something like genetics. You can't really prevent genetic factors from playing out your risk factors for many diseases. So you might move into the sort of at-risk category, where again, you might still be able to control the risk of your disease in some ways, but you probably won't prevent it fully. Then you move on to something that we call an early detection stage. So this is where maybe you already start to have some symptoms, maybe you don't, but they're not necessarily symptoms that are classifiable. So a doctor certainly might not catch them, even though you're technically starting to exhibit some of the disease characteristics. And then you would move on to a diagnosis, potentially being diagnosed with other comorbidities, so other diseases on top of whatever the disease is in question. And then that might lead to death, of course. So this is to say that, yes, this idea of disease and not disease, healthy, unhealthy, it's a really complicated concept, and it's really tempting to reduce it into these types of binary categories, yes, no, disease, not disease. But it's important to keep in mind that it's actually quite a bit more complicated than that. And there's a lot of nuance to disease diagnosis in general. So there's kind of a whole science to that in itself. So the reason I bring that up is that in many ways, a burden of disease study can try to address some of that. And this is why the WHO tried to do a burden of foodborne diseases back in 2015. So the reason that they did that was because foodborne diseases is one of those sort of complicated, very vague diseases that wasn't really well defined. So people around the world thought of foodborne diseases in very different ways. Even the causes of foodborne diseases were not necessarily a standard definition. So it was, dozens of diseases that could or could not be related to something like food poisoning. Now that is because foodborne diseases are caused by a multitude of different factors, right? They're caused by bacteria, viruses, parasites, chemicals in a food source. So there's many different potential paths of exposure or causes that could lead to foodborne disease. But in order to figure out how to prevent them globally, and especially because it is it takes a huge toll on health and on mortality around the world, they did want to be able to define these diseases and to be able to prevent them, to try to put some sort of action in place. So they standardized a lot of those types of definitions, and they did this study in order to really get a sense of what the picture was globally for foodborne diseases. And so, for example, they found out that 33 million healthy life years were lost. Now, that is an example of one of those adjusted life years that we talked about. Does anyone want to guess which one that is? Is it a Haley? Is it a Kaylee or daily? Anybody want to guess? Any ideas? So we're talking about healthy life years lost. Dailies. Yeah, you guys are right. Dailies. Good. Now, this brings us to a very relevant and suddenly very popular field of research, epidemiology. Prior to COVID, I'm not sure that many people knew what epidemiology was or what an epidemiologist did for that matter, but now it's a pretty popular topic, so we'll talk about it as well. Essentially, it's a method of statistical research or other health research in the medical or health sciences that deals with many health measures that we've discussed today. So the CDC, for example, defines epidemiology as a method used to find the causes of health outcomes and diseases in populations. What really separates epidemiology from medicine is that the patient is the community and individuals are viewed collectively. So we're worried about population health, even though we are using individual data a lot of times in epidemiology. We're really focused on the health of populations, not about treating a particular individual with a particular disease. So by definition, epidemiology is the study of the distribution, so the frequency or the pattern, and the determinants, so causes or risk factors, of health-related states and events, which could include diseases, it could include mortality, it can include a whole host of other health events in some population. Now, this could be a population in a neighborhood, it could be in a school, it could be in a country, globally. So again, this is where the role of scale potentially takes place. And so essentially the application of the study is used to control health problems at these various scales, depending on what scale it is that you're interested in. Now, you could argue that most epidemiologists are actually part-time health geographers, right? They're looking at health data, they're looking at health patterns over different spatial scales, over different time periods. So they share a lot of sort of common research interests to many health geographers. That being said, not all health geographers are epidemiologists. So not all geographers related in health research necessarily have the skills or the training to do some of these more kind of mathematical and statistical calculations. So while they might be interested in a similar type of research, they might not necessarily have the experience of an epidemiologist in that sense. So we're going to spend the last little bit of class going over study designs, and hopefully we can get through them all, but if not, we'll pick this up next week as well, because next week we'll also talk about methods. So this is to say that the health indicators we've been talking about are usually found within the context of different studies, and the way that we think of those studies is we try to classify them. So the main three types of study designs that we'll be focused on in this course are descriptive, observational, and experimental. And I'll go through the details a little bit, especially observational. There are subtypes of studies within that, so we'll define those a little bit more clearly. So to start, a descriptive study is a very general sort of study that often looks at broad patterns in a disease over time and space. It's not really looking at establishing any potential causes as to why the pattern is there. It's really just trying to see if a pattern exists at all. For example, in this study by Elimian et al. In 2019, they were interested in looking at the state of cholera in Nigeria. So they were looking at mapping the case fatality rate of cholera across different states in Nigeria. Now, this doesn't tell you what caused cholera to be higher in some places than others. It just tells you that they were. So we use descriptive studies in health research, often just to look at those patterns, just to tell us what's happening at a given time or place. But you can't really use it to establish any causes. You might take that kind of research and use it to do more research to do that later, but it's not really helpful in that sense to tell you whether A causes B. In comparison, the second type of study design, observational, these are the types of studies that do actually try to help us answer why we're seeing a disease outcome the way that we are. So they're really interested in actually looking at potential causes of whatever disease or type of mortality that they're interested in. Now, there are four main observational studies that we will cover. Some textbooks, some readings might describe them a little bit differently, but generally we'll follow these four sort of main subcategories. So the first one, the first observational study that we'll talk about is the ecological study. The ecological study is used to study correlations between exposures and outcomes, again, at a population level. What's really unique about the ecological study is that it doesn't ever go at the sort of subpopulation level. It's never looking at individual level data. It's only looking at aggregated health data at some scale. So it might be in counties, it might be in census tracts, for example, here in Canada, but it's never going beyond that. It doesn't use any sort of hospital records from individuals. It only uses sort of averages based on a particular area. So you can imagine that due to this particular characteristic, the ecological studies do have some limitations. you can't really link individual exposures to individual disease risk factors because you don't have that individual level data. This is something that we call ecological fallacy. And this is where you assume that any associations that you observe in your study, in your research, that you're assuming that they can be observed at the population level the same way that you might at the individual level. Now, I'll show you through this example why we don't think that that's true, why we would be very cautious in using ecological studies to get a sense of what might be happening to individuals. So in the figure there, it's plotting per capita alcohol consumption against heart disease death rates, specifically in males in the 55 to 64 age category. Now, what this figure might tell you, interestingly, is that somewhere like Finland, right? I've circled it there in red. Somewhere like Finland might have a pretty low per capita alcohol consumption, yet somehow the death rates from heart disease are the highest. So if you were to use this type of study to try to establish any causal link, you might think, oh my gosh, drinking less alcohol can cause more death rates. That means everybody should be drinking alcohol. But this is not true. In fact, alcohol, we know, is a disease risk factor for many diseases. So it's an example of ecological fallacy, because what this figure isn't telling you is that individual consumption of alcohol varies quite significantly. Not everyone drinks the same amount. And so pretending like every person in Finland has the same average level of alcohol consumption can lead you to make a lot of erroneous claims like this. So what's actually likely happening is that a handful of people in Finland who are really avid binge drinkers are the ones that are being diagnosed with cardiovascular heart disease and dying from it, whereas the rest of the population is probably more light to moderate drinkers. And so unfortunately, it's those sort of heavy drinkers that are skewing the average death rates, even though the per capita alcohol consumption might look pretty low. So this is why we have to be very careful with ecological studies and why they don't necessarily establish any certainty with associations. They might just sort of point you in the direction that you might need to study a particular relationship a little bit more closely. So this leads us to the second type of observational study, and this is called a cross-sectional. Now, cross-sectional designs provide you with a snapshot of the frequency of a disease among individuals in some population. And usually they're done using something like a survey. So you have some study population, you administer a survey at a particular period in time, and then you would ask people about their disease history, you might ask them about their exposure history, and then you would collect those surveys and you would know that at that period of time when you did the survey, that you had a particular frequency of disease, X, Y, Z, let's say, and that certain people, maybe with the disease, exhibited certain factors that those without the disease did not. So as you can imagine, this can be pretty useful to do with something like a disease burden study if you just want to kind of have an overlook of what the state of a disease is. But since you're only examining the outcome at a single time, you're not looking at it sort of in the future or backwards, you can't really make observations over time, and therefore you can't establish causes definitively. Someone might just be sort of thinking off the top of their head at the present period of time that they're doing the survey, let's say. You can't necessarily establish with certainty that whatever their disease is wasn't caused based on some other factors that they maybe don't remember or aren't thinking about. So that's why a cross-sectional, you also cannot necessarily establish causality, as we call it. Now, the next type of observational design is a case control. So these are used to determine whether individuals in a population with a disease are more likely to have been exposed to something, or they're more likely to have some sort of risk factor compared to those without the disease. So this is cases, those people with disease, versus controls, the people without the disease. Now, what makes it different from the others is that you're working backwards. So usually You're asking people to recall certain factors that they may have been exposed to in the past. You're having them sort of work backwards to figure that out. Something also worth mentioning is that the controls have to be matched based on the cases. So usually you're selecting roughly people of the same age categories. You want to make sure that the sex distribution is similar in both cases and controls. Why do we do this? Well, because you want to make sure that what makes the cases and controls, the only difference between those two groups is the fact that one of them has a disease, one of them doesn't, and that one of them has that factor that you're interested in, that exposure that you're interested in versus the other that don't. So these studies are more likely to determine whether some exposure is associated with the health outcome. So they're a little bit closer to establishing causality, but still not quite, because as you'll see with the next example, the cohort is the only observational study that we can establish causality. This is because you're actually establishing temporality, unlike the others. In a cohort design, you take a study of a population, you take that population and you follow them into the future. You often have to wait many years, sometimes decades, for them to actually develop the disease. And then you take a look at why the people that got the disease got it, what kind of factors they might have had, what exposures they might have had compared to those that did not get the disease. So as you can imagine, these are particularly useful to get a sense of strong evidence that a relationship exists between some exposure and some disease. But because they take so long to do, they can be really expensive, and you sometimes have to wait a really, really long time for any sort of relationship or any cause to emerge in these studies. So that's why we don't see a bunch of cohorts around. Now, the last type of study design is the experimental. And there are many different ways to think about an experimental design, but we're going to keep it pretty simple for the sake of a second-year course. So the best way to establish cause and effect is with an experimental design. Usually they use some sort of randomized assignment. So they might randomly assign a treatment or an exposure to in a group and then follow what the rate of the disease is in those two groups. Now, before we wrap up, I do want to ask you guys, why do you think it's rare that we would use an experimental study in health geography? Why might there be some ethical concerns with using an experimental design in health geography? Any ideas? Long-term health risks? Yeah. Any other ideas? Why are these rare in health geography? Any other ideas? If they contract the disease, it could potentially cause pain or death. Yes, absolutely. So it would be really unethical to experiment on humans if potentially you might be assigning them some sort of deadly exposure. So generally, we try to avoid exposing individuals deliberately to potentially hazardous things. So this is why often you will see in health studies the use of animals instead. This is so that they don't test on humans. So they'll use animals as sort of study substitutes. And then if they can prove that something is safe, they might consider then to carry out some sort of human trial. So yeah, you're subjecting participants to harmful exposures, and we definitely would like to avoid that. Okay, I think I'm going to end it here, and then we'll pick up next week, probably just discussing these different study designs a little bit and refreshing them to make sure that they're clear. But I'm going to end it there. Thanks so much, guys. If you have any questions, I can stick around for a minute or two, but otherwise you guys are free to go. Thanks, everybody.